Hello, everyone, and welcome to Session 2C, the Kentucky Perinatal Quality Collaborative. First initiatives are successful in connecting families affected by substance use to treatment and necessary resources. Our speakers, I'm Shelley Steiner. I'm the Prevention and Harm Reduction Implementation Specialist for the Kentucky Opioid Response Effort. And our speakers for this session will be Monica Klaus and Rita Crum. Ms. Klaus received her master's in public health from the University of Kentucky in May of 2009. From 2010 to 2019, she worked as an epidemiologist in Kentucky's Department for Public Health within the Division of Maternal and Child Health. In October of 2019, Ms. Klaus joined the Association of State and Territorial Health Officials, serving as a local field placement in Kentucky. In this role, she worked to enhance the KDPH's capacity to develop and implement goals in critical areas for Kentucky's opioid use disorder, maternal outcome, and neonatal abstinence syndrome initiative, and assisted Kentucky in establishing a perinatal quality collaborative. Ms. Klaus is now employed with the University of Kentucky and serves as the program manager of Kentucky's Perinatal Quality Collaborative. Ms. Klaus has received her certification in public health. Rita Crum is the Women's and Children's Health Services Line Director for Appalachian Regional Healthcare. She provides leadership for the growth and development of women's OBGYN, breast centers of excellence, etc., and children's, pediatrics, NICU, etc., health throughout the ARH enterprise. She drives operational, financial, and clinical surgical excellence in collaboration with ARH CEOs, system local leaders, and regional chief medical officers. She has over 28 years of experience in education, nursing, and healthcare leadership with an emphasis in women, infant, and children's services, emergency room nursing, hospital education, and healthcare accreditation. I'd like to get started with Ms. Klaus. I think it's going to be our first speaker. And if you have any questions, please put them in the chat, and I will keep up with those so that at the end of their presentation, we can have those questions and answers.
Great, thank you, Shelley. So as Shelley said, I am going to review or go over Kentucky's Perinatal Quality Collaborative, and we refer to ourselves as the KyPQC. And I'm going to discuss how we came about of developing our first quality initiatives. And then later on in the session, we will hear from Rita on how these initiatives have been successful in connecting families affected by substance use to treatment and necessary resources. So again, here are the presenters of this session. And we both have no financial relationships to disclose. By the end of this session, we hope that you will be able to describe the focus of the KyPQC First Quality Improvement Initiatives and how these topics were selected. We also hope that you will be able to recognize the importance of having a peer support specialist on hospital teams when conducting quality improvements for the care of pregnant patients with substance use disorder. And lastly, we hope that you will be able to outline the importance of connecting families affected by substance use disorder with community resources and treatment options. So first, let's just review the background which led to the development of a statewide perinatal quality collaborative in Kentucky. Among many other states, Kentucky faces a significant substance use disorder problem, which has resulted in an increase in the number of babies born with neonatal abstinence syndrome, or NAS. According to the 2021 Kentucky's NAS annual report, the rate of NAS in Kentucky consistently remains 3 times higher than the national rate, with the most recent national estimate for NAS being 6.8 cases per 1,000 live births. And as you can see from the graph on this screen, Kentucky's NAS rate in 2020 decreased from 2019. However, preliminary data for 2021 reveal that Kentucky's NAS cases are increasing. This really does not come as much of a surprise due to the numerous burdens of the COVID-19 pandemic. The Kentucky Maternal Mortality Review Committee found that a substance use contributing factor was the #1 cause of maternal death in Kentucky for 2017, 2018, and 2019. And more specifically, looking at the 2018 data shown here on the screen, there were a total of 76 maternal deaths in Kentucky, and substance use was a contributing factor in 53% or 40 of these deaths. And it's important to note that in Kentucky, a maternal death is defined as any female between the ages of 15 and 55 that was pregnant within 1 year prior to the death or pregnant at the time of death and died from any cause. So the data that was just presented here reveal that substance use disorder in the perinatal setting is a major public health problem in Kentucky, and that efforts really needed to come together to combat this crisis. So in 2018, Kentucky was selected to participate in the Association of State and Territorial Health Officials Opioid Use Disorder, Maternal Outcomes, and Neonatal Abstinence Syndrome. And for short, this is also known as the Omni Learning Community. So several important Kentucky partners came together to participate in this learning community. Some of these partners included the Kentucky's Department for Public Health, as well as the partners from Division of Maternal and Child Health, Kentucky's Hospital Association, the Department for Behavioral Health, Developmental and Intellectual Disabilities, as well as Medicaid. And as a result, these partners developed an action plan to address maternal outcomes and NAS with an overarching goal of developing a statewide perinatal quality collaborative. And the aim of this collaborative would be to reduce rates of maternal mortality and neonatal abstinence syndrome and improve the overall maternal and infant health outcomes throughout the Commonwealth. And then in 2019, the Kentucky Injury Prevention Research Center, which is a bona fide agent for Kentucky's Department for Public Health, was awarded a CDC grant called the Overdose Data to Action, or OD2A grant. And Kentucky, the Kentucky Department for Public Health was selected as a subrecipient of these OD2A funds under Strategy 7, which was Provider and Health Support System Activities. So therefore, Kentucky decided to use these funds to develop that statewide perinatal quality collaborative. And this resulted in the official launch of the Kentucky Perinatal Quality Collaborative, or as we refer to ourselves as the KyPQC. And this launch was held at Churchill Downs on October 22nd, 2019. And if you look here at the picture on your screen, that little red circle indicates where this launch meeting was held. Soon after the KyPQC was developed, we established our logo, which is shown at the bottom of this screen. And we also began to work on bringing together our vision statement, which is working together to make Kentucky a great place for every woman to have a baby and a great place for every baby to be born. And we also began immediately to create an official KyPQC website, because everybody knows that you're not truly a program or an organization until you have an official website. So we are very proud to announce that this website is now publicly available at the address shown at the bottom of this screen at kypqc.org. And then we also built our KyPQC organizational structure. which consists of the steering committee, which has representation from vital KyPQC stakeholders and advisors from across the state, including a peer support specialist. And the role of the steering committee is to ensure that the quality improvement initiatives that are developed by the work groups align with the vision and the mission of the KyPQC. This organizational structure also includes the KyPQC Central Office, which is made up of a medical advisor, a program manager, a health policy specialist, and an epidemiologist. As a whole, this central office coordinates meetings with all three of the work groups, as well as the steering committee. And we also develop and distribute valuable resources and information through a listserv of our KyPQC stakeholders, and we work very closely with hospital teams implementing quality improvement initiatives. The three different work groups shown here, which is the NEO or natal work group, the data and analytics work group, or just data, and the obstetrical or OB work group, all have leaders who volunteer their time to conduct evidence-based research to aid in the development of quality improvement initiatives. Once these quality improvement initiatives and the necessary resources are developed, then they are presented to the KyPQC steering committee for approval to recruit hospital teams to implement such initiatives. Altogether, the KyPQC Central Office, as well as the work group leads and work group members, work very closely with these hospital teams implementing quality improvement initiatives to provide any needed support as well as technical assistance. So now we will change gears and talk about how the KyPQC use data to inform the focus of our first quality improvement initiatives that are currently being piloted by some of Kentucky's birthing hospitals. So to ensure that these first initiatives met the needs of Kentucky's birthing hospitals, the central office and the work group members developed two baseline surveys, which included a NEO baseline survey and an OB baseline survey. The NEO survey was developed to learn about birthing hospitals' current reporting practices of NAS to Kentucky's Department for Public Health's state registry. And the OB baseline survey was developed to learn about birthing hospitals' current screening, pain management, and evaluation protocols for pregnant women with substance use disorder. Both of these surveys were distributed in January of 2021 to all 46 of Kentucky's birthing hospitals. And here, shown on the screen, are just some of the overarching results from these baseline surveys. For both surveys, we had an excellent response rate. First, I will start with the NEO survey, where we had 87% of the hospitals respond. We identified that 33 of those responding facilities were familiar with Kentucky's revised statute 211-676, which makes NAS a reportable condition in the state of Kentucky. This survey was also able to identify 37 individuals in the hospitals that were responsible for reporting those NAS cases to the state registry. However, we learned that reporting practices varied among hospitals, as well as so did the definition of NAS. And lastly, we learned that the majority of these facilities were interested in receiving training on entering in NAS cases into the state's registry. For the OB survey, again, we had an excellent response rate with 89% of Kentucky's birthing hospitals responding. However, we learned that only 13 facilities reported a current use of a substance use disorder screening tool, and only 4 had a current protocol for pain management for women with substance use disorder. And again, the majority of these facilities were interested in implementing screening and protocols. These results also steered the next step for the work groups, And the KyPQC learned that the NEO work group really needed to focus on educating hospital staff on the requirements of reporting NAS cases to the state's NAS registry, as well as educating those hospitals who transfer infants to a higher level of care that they are still responsible for reporting those NAS cases to the state's registry. We learned that we needed to educate on the distinction between making a report to Child Protective Services and reporting an NAS case to the registry. And then most importantly, we learned that we needed to determine a set definition for symptomatic that could be used by all of Kentucky's birthing hospitals. And lastly, we learned that we needed to streamline this data entry process and make recommended edits to the REDCap data entry form to help ease the burden of entering these cases on hospital staff. For the OB work group, the KyPQC learned that we really needed to promote the use of a standardized screening tool to improve the identification of women with substance use disorder in the labor and delivery setting, and that we needed to establish a pain management protocol for these patients. We also learned that we should establish a quality improvement tool that evaluates the effectiveness of pain management for these patients. We learned that it would be important to develop training and education programs that address both inpatient and outpatient provider management of women with substance use disorder and support appropriate prescribing behaviors that is consistent with the current guidelines. And lastly, and maybe most importantly, we learned that we needed to promote a culture of change in the labor and delivery setting that balances evidence-based processes of care with empathy, non-stigmatizing language, and the engagement of key partners that provide essential resources and social support services to these families. So in conclusion, we learned that these first initiatives really needed to focus on providing education and guidance on reporting NAS cases, as well as substance exposed newborns to the state's registry, and establish a standard definition of NAS as well as substance exposed newborns for reporting purposes. And for the OB initiative, we learned that it really should focus on promoting the use of screening tools to improve the identification of patients with substance use disorder in the labor and delivery setting, as well as establish a standard protocol of care for these patients. And not only did the data from the baseline surveys steer the desired outcomes for the KyPQC first initiatives, it also led to the selection of the birthing hospitals participating in the first cohort of pilots for these initiatives. The KyPQC aimed to recruit pilots based on varying responses to this baseline surveys, as well as in regards to the hospital size, in looking at the number of births per year or the level of care of their nursery. And we also wanted a wide geographic representation across the state, which you can see here from this map. And also on this screen, you can see that there were a total of 9 Kentucky birthing hospitals that were selected to participate as pilots and who are currently implementing these first initiatives. These pilots were given the option to participate in just one initiative, either the OB initiative or the NEO initiative, or they had the option to participate in both initiatives. We are very happy to announce that 8 of these 9 facilities chose to participate in both initiatives simultaneously. So by the conclusion of this first cohort of pilots, we hope that those participating in the NEO initiative, we will see a decrease in the percentage of pilot hospitals with no NAS case reports or underreporting to the state registry to 0 by October of 2022. And then for the OB initiative, we hope to see a 100% increase in the percentage of pilot hospitals utilizing a substance use disorder validated screening tool for patients who are admitted to labor and delivery by October of 2022. So once these first initiatives, or as I like to refer to them as baby initiatives, have been piloted, the KyPQC will work with these first cohort of pilot facilities to expand the focus of these initiatives to encompass the overall global aims. And the global aim for the NEO initiative is to really improve outcomes for infants with NAS and or with intrauterine substance exposure. And we would like to do this through the development of standardized care protocols for these infants and through the establishment of a multidisciplinary trauma informed approach to plan of safe care. And the global aim for the OB initiative is to improve perinatal pain relief for women with substance use disorder through the development of pain management guidelines during the intrapartum and postpartum periods, as well as develop a comprehensive list of community resources for pregnant and postpartum people with substance use disorder. And lastly, I would like to note that in March of 2021, Kentucky officially became the 41st state to join the Alliance for Innovation on Maternal Health, also known as AIM. AIM is a national data-driven maternal safety and quality improvement initiative. And these initiatives are working towards reducing preventable maternal mortality and severe morbidity across the United States through various patient safety bundles. So therefore, the KyPQC designed our first initiative to prepare hospitals for the implementation of AIM's Care for Pregnant and Postpartum People with Substance Use Disorder Patient Safety Bundle. So with that, I would like to thank everyone, and I would be more than happy to answer any questions at the end of the session. But for now, I would like to turn it over to my colleague, Rita Crum, who will provide a hospital's perspective on implementing these first quality improvement initiatives.
All right. Make sure I'm sharing my screen here. Can you guys see my screen?
Yep, all good.
Okay. Thank you, Monica, very much. And I just have to say that at ARH, Appalachian Regional Healthcare, we are very thankful that we are part of this project. It's already brought some wonderful changes and helping us to do better to take care of our patients. What I'd like to start with is just a little bit of an idea of who we are at Appalachian Regional Healthcare. So we are a healthcare system in the Appalachian region. We are ranked in top 10 employers of Kentucky by Forbes magazine. So of course, we're very proud of that. We're a not-for-profit health system operating 14 hospitals. That's our current count. We have many multi-specialty physician practices throughout our regions, home health agencies, long-term acute care facilities, durable medical equipment retail stores, and retail pharmacies. This shows you our ARH service area map, so you can see our 14 hospitals that are listed. So we're primarily in Eastern Kentucky, but we also spread our wings a bit in West Virginia, so that's part of our service area as well. We have 5 birthing hospitals across our system, and all 5 of our hospitals are participating in KyPQC's first QI initiatives. Those hospitals are Hazard Regional Medical Center, Highlands ARH Regional Medical Center, Whitesburg ARH Hospital, Harlan ARH Hospital, and Middlesboro ARH Hospital. So just to talk a little bit about how it all started, I know Monica touched on that as the program as a whole, but for us specifically, when the recruitment process, when KyPQC went through the recruitment process, they reached out to Highlands, which is one of our birthing hospitals in Prestonsburg, Kentucky. and invited them to be part of this set of initiatives. What happened at that point is ARH system leaders had meetings between the quality department and the local leaders. We had one hospital, Hazard Regional Medical Center, who was involved with pretty heavily with some core grant initiatives, and we didn't want to interfere with any of those initiatives. But ultimately, at the end of this meeting, the decision that ARH made was, we would like all of our birthing hospitals to participate. So after talking with KyPQC, all of our birthing hospitals across our system, the 5, signed one agreement to participate in both the neonatal and the obstetrical initiatives. Honestly, all of that happened prior to me accepting this position at ARH. I accepted this position in March of 2022, the service line director for women's and children's health. It was excellent timing because we were just getting started with everything. And my job primarily is to pull all of our hospitals in terms of women's and children's health services, to pull us all together and have us all on the same page and working together. So it just all worked out really well. But I have to be honest and say that sometimes I kind of felt like I was jumping on a moving train. But it's been wonderful so far, and I think we're doing a really good job with this program. So to talk a little bit about how it's going, we'll start with those newborn initiatives. We're obviously in that implementation phase, so we're just getting started. We have reported data through the Red Cap for May and June. We report data on the 15th of each month, so we're getting ready to report our data for July. All of our early follow-up meetings have been completed, so I just really have to brag on Monica and her team and KyPQC. They've done an amazing job at communicating with us and making sure that we're doing that all of our questions are being answered and that they're there to support us as we're moving through these initiatives. So we are reporting all of our neonatal abstinence syndrome infants to the state's NAS registry. We have staff education in progress. When we started this project, we had a limited number of employees across our system that were trained in entering the data. Our goal is to have 2 per hospital at minimum. For the most part, we're meeting that now, but we've had some staff turnover, as you can imagine, and so there still is some education to be done at this point. But the education that KyPQC has provided has been very beneficial. So some of the actions that we have put into place to encourage that we sustain these newborn initiatives, just KyPQC working on reports to indicate who's completed education at each location. So what KyPQC is providing for us is a list of the people that have actually completed the education, so that I know who to reach out to at each location to be able to improve the education percentage at that particular facility. And then they'll add the NAS data entry education completion to quality dashboard to report to senior leadership. So when I receive this information, this will be something that I add to my quality dashboard, and I'll be able to report this to the senior leadership so that we can make sure we're maintaining or reaching and maintaining our goals. And as I said earlier, our goal is to train at least 2 staff members at each location. So how's it going as far as our OB initiatives? Again, the implementation phase began in May of 2022. We have reported data for our OB initiatives for May and June. We're getting ready to report July's data. All of our early follow-up meetings have been completed. Each hospital created some binders to be able to organize all of their screening tools, their SUD screening tools. Staff education in our hospital learning management system has been completed, because what we actually have done has we have transitioned our 5 Ps assessment that we're utilizing to our electronic medical record to make it easier for the nurses to complete. We have done some troubleshooting, and as you can imagine, anytime you try to translate something into that electronic environment, sometimes there are issues that pop up, but those were quickly resolved by our IT team, and we've provided some re-education since we went live on July 15th. I did want to talk a little bit about the 5Ps assessment tool and why we chose the 5Ps. So KyPQC really, what their initiative was that we were using an evidence-based tool. One of our hospitals was using a tool prior to becoming part of this initiative or project. But what KyPQC did was recommend 5Ps. And so we took a good hard look at it across our system. And we decided that we would go with the 5Ps assessment across our system, mainly because it addresses the risk related to personal contacts and it's a non-confrontational line of questioning. So if you're not familiar with a 5Ps assessment, it starts out with questions. So as you admit your patient to labor and delivery, and you kind of want to start this conversation with them to try to identify those that are at risk, the conversation starts with just the people that are around them. So do you have parents that are using substances? Do you have, is your partner using substances? And what we have found is that that's less confrontational for the patient. So you start those conversations asking about the people around them, and then that line of questioning becomes more personal, and you start to ask them questions about their if there's a possibility of substance use with them. So we felt like it was the best tool to use, and we wanted to be standardized across our system. So that's what we did. As far as that 5Ps assessment in our EMR, if they answer a yes on that 5P assessment, it will actually trigger further assessment with the Audit C tool and expert tool. And it will either trigger a follow-up with a peer support specialist, depending on the hospital that you're at, or counseling and interventions with social workers. And those peer support specialists and social workers will have recommendations and assistance with outpatient treatment programs. And of course, like most places, some of our communities have more resources than others. So we try to communicate with each other so that we can share resources across the system. So I wanted to make sure that I touched on the importance of our peer support counselors. When Monica asked me to just talk a little bit about our involvement with this KyPQC initiatives project, I reached out to one of our peer support counselors at Whitesburg, ARH. Her name is Christy. Christy is a 34-year-old wife and mother of 2 beautiful children, and she has been with ARH for 3 years now. I asked Christy if she would share her story and just, how she felt about being a peer support counselor at Whitesburg, and just the work that she did. And she responded with her story, and I'm going to be completely honest with you. I cried through most of it. Part of those tears were a little bit sad, just because of some of the life experiences that she had lived through. And then the other part of it was just overwhelming pride that we were blessed enough to have someone like Christy with us and helping us with this program. She is an amazing human being, and I'm going to warn you ahead of time and apologize a little bit ahead of time. I paraphrased some of her story, but there was a lot of Christy's story that I just wanted to be able to repeat verbatim, because I think everybody really needs to hear her words. So I've never been a fan of a lot of words on a screen, and I'm definitely not a fan of reading them word for word, but I feel like in this instance, you need to hear it. And I don't think that I would do Christy's story justice if I didn't share verbatim some of the words that she shared with me. So Christy talked about in her story how she's been using since she was a teen as far as substances go. So she started with various substances in her teen years, and then in her early 20s, opioid addiction became a huge issue for her. So Christy said that her journey has had many different layers, and over the years, Christy's tried many programs to try to manage her substance use, and she's just relapsed at the end of the program, is what she said. Both of her children were born addicted and had to be placed on medication because of her substance use. So Christy, to me, has a unique understanding of our moms that are using substances, and she definitely has a special connection with them. And again, it's like I said, I just feel very blessed that we have her working with us with this program. Christy's turning point, she says, when you are substance using and find out that you're pregnant, the excitement of pregnancy is lacking because of the guilt that you hold. You know that the issues and reasons are caused by your own doing, but there's something that has hold of you and it won't let go. And I think that's such a powerful statement. In general, pregnancy is a very exciting time for not only our moms, but also the families. And to hear her in her own words talk about how the guilt just really overwhelms the excitement of pregnancy, it's heartbreaking. During this time, Christy says, I looked at all the issues that myself and my baby were going to be facing. And as a mother, we want to make the best possible decisions that we can. So that's when I decided that I needed to enter into a medical assisted treatment, an MAT program, because I knew I couldn't stop on using on my own. I wish that we had the facts and resources that we have now with MAT programs 11 years ago. At the time, it was very hard to meet the requirements that came with being in a program. 11 years ago, medical insurance did not provide any coverage for MAT programs, and the requirements to get in a program were very complicated. So I was not fully compliant with the program that I was in. Christy's daughter was born in November of 2012, and Christy says, I wish that I could say it was a wonderful experience, but it wasn't. Due to being non-compliant with my program and the level of withdrawal my daughter was having, she had to be sent to the University of Kentucky Hospital and placed on medications, where she stayed almost a month before being discharged to come home. She was discharged home on medications and then was slowly tapered off. She is now a very vibrant 9-year-old, and we have been very lucky that neither one of my children had any long-term effects from my substance use during my pregnancies. So for 7 more years after her daughter's birth, Christy struggled with sobriety. To paraphrase, there was jail time. There was an uncertainty by family as to even how to help. And there was a heroin overdose. The bright thing is recovery is possible, and Christy speaks to that. She says, as an addict in active addiction, we feel that recovery is not possible, that we are lost causes that aren't worth saving, that being an addict is all we will ever be. But that is not true in the least. Every person in addiction is worth saving, showing them that recovery is so much less complicated than we make it out to be in our minds, that there are people in our community that are willing to help you. With this program in our labor and delivery department, if anything, it provides patients with someone who has personal experience that can relate to all the emotions and feelings they're having. Also letting them know that they are not alone. Assisting patients, linking them with the resources that are available can help give them, their children, and the families better quality of life. Letting patients know that if at any time they need help or someone to talk to who cares what happens to them is really what peer support is all about. If we can save one life or make a difference to one patient, then what we have done is well worth it. I try to make sure that all patients I have seen, whether in OB or in the ER, Christy also works in the ER, know that no matter what the situation is, there is someone here that's willing to help, because I still wonder to this day how my situation could have been different if I had had someone that was willing to help me fight my addiction and show me how the road to recovery was much easier and that I wasn't alone. So I still get emotional just reading all that and thinking about it. And I definitely appreciate Christy sharing that story with us and with me. So then what I'd like to talk about now is just connecting moms with resources. And so in one of our hospitals, we have a patient care navigator in Hazard. Her name is June. So June has been in her position for a few years now, and she's actually a dedicated social worker that works on OB. Now, I know that some of you are probably familiar. We don't use the term social worker. It sometimes is a little bit intimidating. So June is known as our patient care navigator, and that's how our patients know her. The thing about June is, and the thing that you need to know when it comes to connecting moms with resources, is that it's more than just giving them a list of resources upon discharge. It is an active involvement in the community organizations. So what June does is actually build a relationship, and she networks with the organizations that are available in the community and the people that are in the community. And it's amazing. And I wish that everyone had the opportunity to talk to June. And we also wish that everybody had a June on their staff. We say that all the time, but just the amount of involvement that she has, how she's actively involved. And she'll tell you, she says, you have to be personally invested. And you have to put your words into action. So she goes to a lot of meetings. She reaches out to a lot of people in the community. She does on-site visits to organizations, and because of that, that's how she learns about resources that maybe a little faster than what other people do, or maybe a little faster than what we normally would as in the hospital. And her active participation and just really connecting with the resources that are available in the community have also lended themselves to the hospital receiving additional supplies, like car seats and Narcan and even housing. I mean, she's been able to secure some housing for some of our patients, simply because she has done a lot of networking and worked very closely with the resources that are available in the community. So most important, just make sure that you take away when it comes to connecting these moms with resources from that inpatient hospital side, that it doesn't end at discharge. You still need to make some follow-up calls, troubleshoot barriers. June has told me stories about calling moms after discharge and making sure that they're making their appointments and their meetings and things like that they need to do, and see if they need anything. And like I said earlier, she's been able to secure housing. She's been able to secure some transportation. But the job for June most definitely does not end at discharge. She's very actively involved, and we're very proud of that. So very important to us is that we make sure that we encourage sustainability of our OB initiatives as well as our NEO initiatives. So the implementation of the 5 Ps assessment into our EMR was very important to us because it makes the job a little easier. What happened is when a patient is admitted to labor and delivery, that 5 Ps assessment will automatically populate to the nursing assessment list. When for the nurses to complete upon admission, if there is a yes trigger or any kind of, if it triggers that particular assessment triggers an action, then further interventions will pop up on that list of things for the nurse to do, or the patient navigators, or depending on where you're at, or peer counselors. but those interventions, like I mentioned earlier, the Audit C and SBIRT, those get completed. So it automates things and just kind of helps. What it also allows us to do is devise some reporting, some electronic reporting that goes to the managers of each unit, and that makes their reporting to KyPQC a lot easier for them as well. So the EMR generates reports tallying the 5 Ps and interventions, making the data easier. I already said that. Service line director commitment. So what is my commitment to making sure that we sustain these OB initiatives? Well, it's part of my personal incentive plan for my job. And I have quarterly meetings with our local leaders. We share experiences. The percentage of admitted patients screened for SUD was added to my quality dashboard and reported to senior leadership. So in a nutshell, we're all in. We're all in, from our nurses at the bedside that are providing direct care through our local leaders, and all the way up through our chief leadership. And the last thing that I want to end with is just to simply say that, for us, involvement in this KyPQC in the initiatives is extremely important. We feel we believe that pregnancy is an excellent opportunity. So pregnancy and childbirth is an excellent opportunity to reach these moms, and what we find is that they're oftentimes more open to building relationships with us, and us being able to get them the resources and help that they need.
There is one question from Alice Ross, and it says, will the 5 Ps of the assessment be given?
So I will answer that question. Right now, as I said in the presentation, that we are in our first cohort of pilots for these first initiatives. And we are planning to implement these initiatives with a second cohort of pilots. And then really the reason for the pilots is to kind of fine tune everything, make sure that all of the resources, everything is ready and perfected before we release statewide. So once we complete our second cohort of pilots, then all of the tools and resources will be available on the KyPQC website at kypqc.org.
Anyone else has any questions, please put it in the chat and we'll be happy to ask for Rita and Monica. So are there other assessments that you use besides the 5 Ps, or that you recommend that they use?
Yes. And Rita might be able to talk a little bit more on what they found most helpful. But for the KyPQC, we really promoted the 5 Ps as a screening tool. We did not limit and say that that's the screening tool that you have to use, because we wanted the pilots to really select what works for their hospital environment and as well as the patients that they serve. And so we recommended a couple of the screening tools, but the main thing is that we just wanted to make sure that those screening tools were evidence-based and were really user-friendly in the labor and delivery setting. CERP-P is another one, or a second follow-up screening tool that the KyPQC also recommends. SERP, I just looked it up, stands for Substance Use Risk Profile Pregnancy Scale.
I think probably Monica to add to that, I don't know that I'll be honest with you, and I'm not really sure what the name of the assessment tool that Hazard was using prior to using the 5Ps, but I think we more or less just added 5Ps to Audit C and Expert. Audit C is more along the lines of like alcohol use and things like that, and then Expert is what allows us to move into that intervention phase. So I guess it's a little bit of an assessment, but it's more so the intervention part at that point. So.
Robert Mason asked, are similar programs available in Central Kentucky or other locations?
So I'm not sure if Robert is with a particular birthing hospital or not, but again, like I said, we kind of went through the determination of selecting our first cohort of pilots based on their responses to those baseline surveys, as well as hospital size and location across the state. And we are currently in the process of recruiting our second phase of pilot hospitals for these first initiatives. And then once they are piloted or completed through the second cohort, then the initiatives will be available statewide and for any hospital to implement on their own.
So then do they need to get in touch with you if they're interested?
Yeah, definitely. You can email me directly at mklaus@ky.gov, or we also have a KyPQC@ky.gov email, and you can get in touch with anyone on our team.
Robert said he is a clinical social worker, but this data is very informative.
Thank you. And
questions?
Dr. White posted our KyPQC@ky.gov in the chat for anyone who would like to reach out and contact us.
Any more questions for Rita or Monica? Do you all have any final things that you all would like to say to our participants?
I mean, I would just like to say that how very proud I am of all the work that has been done, not only from the KyPQC, but also from all of our work group members and pilot hospitals. This is a collaborative, and everyone's time and effort is volunteered to make this successful. And we are just so happy that we are in the implementation phase, and we have received nothing but positive and favorable feedback from all of the 9 pilot hospitals that are participating in this first initiative. So I just want to give a shout out and thank you to everybody who has helped make this a success.
Okay, so we want to thank Monica and Rita for your presentations and for our participants for your questions. Our next session is in the main session room. It will be the closing keynote given by my boss, Dr. Katie Marks. It's the Kentucky Opioid Response Effort Harm Reduction Principles and Strategies. So we hope you'll move on over there. And thank you all for participating today.